We've got quite a few people have joined. I think there are some more due to come on in, but in the interest of time, I think we will kick off. So welcome everybody. Thanks for joining our first SafeCare BC and Care for Caregivers COVID-19 vaccination question and answer webinar. I'd like to welcome Dr. Manish Sadarangani from the University of BC, who's here today as our expert to hopefully answer some of your questions and give you some more information on COVID-19 vaccination. So this webinar is a follow-up to the vaccination survey that SafeCare BC ran in December, where we asked about people's attitudes, people's perceptions of COVID-19 vaccination in continuing care, and lots of people came back with questions and things that you wanted more information on. So Dr. Sadarangani is going to give a brief presentation to start with to cover off some of those questions that came through in our survey, and then we will move on to Q&A. So I know some of you have submitted questions ahead of time through the website, and I've got those. If you have questions that you want to ask live today, I'd ask that you enter those in the chat as we go, and we will work through as many as we can, time allowing. So in terms of tech, just to let everybody know, this webinar is being recorded and it will be posted on the SafeCare BC website. And if you have any technical issues, please message Jen Lesage in the chat. She's here from SafeCare as our tech support today. So with that, I will hand over to Dr. Sadarangani.
Thanks, Jennifer. And thank you for the invitation to come and talk to you all. And thank you for taking the time out of your busy days to come and listen. So I'm just going to share. So I've just got, I know this is mainly supposed to be a Q&A, but we thought it would be helpful to just have a few slides with a bit of an overview that goes through a lot of the common questions that have been received. So that's who I am. So I'm a pediatric infectious disease doctor. I work at BC Children's Hospital, and I'm also director of the Vaccine Evaluation Centre, where we do vaccine research, including COVID research, and I split my time between those two different things. So just for full transparency, so my salary is paid from various local, provincial and federal sources, as well as from the University of British Columbia. And then I have had projects funded by various different companies that are involved in vaccines, and all the money goes to UBC. I haven't received any personal payments, and I don't make any money out of any of those activities. So I just wanted to first of all just talk through a little bit about how vaccines are developed and how that has been adapted in a pandemic. So this is the traditional route, and you can see the first thing is things go step by step, and you complete one step before you go to the next step. And so a lot of activities take place in here, what's labeled as academic and preclinical research. So this is where vaccines, or potential vaccines, I should say, are tested in the lab to try and, things like to see if they're stable as a drug. They're tested in animal models to see if they are safe and to see if they work in animal models. And I would say most potential vaccines that are developed probably don't even get beyond this initial stage. Anything that looks like it's promising in these initial stages are then advanced into clinical trials. And as soon as you get into clinical trials, what we mean by that is that these are then being tested in humans. And so as soon as it gets to the point where you're wanting to test anything in humans, then it needs to get approval from Health Canada, even for the clinical studies to happen. And this is also all done stepwise. So in the first phase, these phase 1 trials are essentially safety studies where we vaccinate small numbers of people, usually tens of people, and even that you usually just do 1 or 2 people first, and then gradually work up to a few tens, so maybe 50 to 80 people. They're usually essentially really healthy adults. There's a lot of blood work and a lot of assessments done to make sure that these are relatively healthy people to start off with, and also to evaluate the safety of the vaccines. And this is really all it's about. At this point, we're just looking to see if vaccines are safe. If the vaccines do look safe in these early trials, then they go to the next phase where you have an increasing number of people. So this is usually hundreds of people. You would probably then at that point spread into getting more towards the ultimate target population. So for vaccines that are being developed for kids, this is when you would start vaccinating kids. For vaccines that are being developed in older age groups, likewise, and you'd start to include people who may have other medical conditions at this point. So these are usually hundreds of people. Again, the safety is the primary goal, and then we also measure what's called immunogenicity. So that's measuring the immune response to see that these vaccines will, lead to some sort of immune response. And then after this phase, if vaccines continue to look safe, and if you're finding that it does lead to an immune response, we go into these big phase 3 trials. And these are essentially the definitive studies which will tell you if a vaccine works or not. And what happens in these trials, essentially, if you volunteer, and some of you may have volunteered in some of these, is you get randomly selected. Everyone's randomly assigned to either get the vaccine or get a placebo. So the placebo sometimes is a completely unrelated vaccine, or it may be a saline solution or something like that. And so half the people, and these are usually in thousands or tens of thousands of people, half the people will end up getting a vaccine. So in this case, they'll get a COVID vaccine. Half the people will not get a COVID vaccine. And then you follow up those people to see who gets COVID disease or who doesn't. And you can essentially, at the end, you compare the two groups to see whether more people had COVID in the group that had the vaccine or the group that did not have the vaccine. And anything that is successful through these efficacy trials and show that the vaccine prevents the infection or the disease will then have to be submitted to Health Canada to finally get approval, and then that's only after it's got Health Canada approval it can be used in people outside of a research setting. In terms of the manufacturing, at the beginning, there's just a small amount of product made because you don't know at this early stage whether something is going to work or not. And then only after the phase 3 trials normally will a large amount of product be made for manufacturing and then ultimately for distribution. Because really, it's not until the phase 3 trials have data that you can tell. And this is a very expensive process. And normally, for something that is successful, this takes 10 to 15 years, and often can take much longer than that, sometimes decades. So in a pandemic setting or any sort of outbreak setting, clearly we don't have 10 to 15 years to wait for a vaccine. And so there's a need to try and speed up this process. And so what happens is that there's a lot of the phases end up overlapping. So the preclinical phase builds on any work that has been done previously with similar vaccines or similar products. Anything that looks promising then goes into phase 1. So the phase 1 trials while they would normally follow people up for 1 or 2 years, in this case, we know that for vaccines, most of the side effects that are going to occur in the first few days after vaccination, maybe the first few weeks. And so once we have that initial data, then we can accelerate into phase 2, and likewise moving from phase 2 to phase 3 once we have that initial data. The other thing that speeds up this process is that there's a lot of approvals that are needed in between the start and the finish, from ethics boards locally, from Health Canada, etc. And normally, if you're trying to do this, you would just go in the queue behind everything else. But for COVID vaccines, essentially, and for all other COVID drugs, they just go to the top of the queue. So everything else gets pushed down. And so that also speeds things up a lot by essentially queue jumping to the front of the line. It doesn't mean that the review is any less rigorous, but it just means that things are able to move much more quickly. And then the other piece is, also all of these trials rely on volunteers. And I think there's been incredible interest and enthusiasm in people volunteering for these studies. So there's not been difficulty in any of the trials really recruiting people to enter them. The other piece that speeds things up is that the large-scale manufacturing has been occurring for many of these vaccines before the phase 3 trials have been completed. And this clearly is a financial risk that has been taken on in part by the companies and in part by governments that have been working in collaboration with companies to say that, we don't want to get to the end of the phase 3 trial, know that a vaccine works, and then have to wait weeks or months for the vaccine to be available. And so for those that look most promising, that large-scale manufacturing has occurred early, so that as soon as you have the phase 3 trial data, we can say, actually, let's get this vaccine used, within days, which is what's happened. And by doing this and accelerating it, we've managed to get a vaccine essentially in less than a year. So in Canada, there are currently 7 vaccines that the government has signed agreement with different vaccine manufacturers. 2 that are currently being used in Canada are the one made by Pfizer and BioNTech and Moderna, and these are both RNA vaccines. And the efficacy is over 90% for both of them, and I'll briefly talk about what that means. The third vaccine here, which has reported efficacy data, is a vaccine developed by Oxford University and AstraZeneca, which has 70% efficacy. And then these other vaccines that are still in clinical trials, and we're still awaiting data. So what does the efficacy mean? So this graph here just shows, so on the x-axis, this just shows over time after people are vaccinated out to 120 days or 4 months. And then up on the y-axis shows the number of, is a representation of the cases of COVID that occur. So if we first track the blue line, that shows you the people who got placebo. So in this particular trial, this was the vaccine that's made by Pfizer. The placebo was a saline, and what you can see is over this 4-month period, essentially as time goes on, the number of people who have COVID just continues to go up at a pretty steady rate and just increases and increases. So it's pretty clear from that that having the placebo had no impact on your risk of getting COVID. What you can see in the red lines are these are the people that were vaccinated, and for the first couple of weeks after they're vaccinated, the line looks very similar and it makes no impact. But then after about 2 weeks after their vaccination, it's almost completely flat, and there's very, very few cases of COVID occurring in people who are vaccinated. And so this trial had over 40,000 people, half had the vaccine, half had the placebo, and you can see the numbers here. So in the vaccine group, 8 people got COVID, and in the placebo group, it was 162. And when you do the math on that, that means that this vaccine is 95% effective to protect against COVID disease. In terms of the populations in these trials, so it was around 50-50 male-female, about 40% of people were aged over 55 years, and then you can see the race ethnicity breakdown of this population. This is done based on the way it's classified in the US, so the trial was done mainly in the US, so it's predominantly white, but a significant number of Hispanic, Latinx people, and 9% Black or African American, with smaller numbers of other groups. These are similar data for the Moderna vaccine, which is also being used. And while the colors are different, essentially the pattern is exactly the same, and you could almost put these two graphs on top of each other. In this case, the gray line here shows the COVID cases in the placebo group. And again, you can see over a 4-month period, the people who had the placebo vaccine just continue to go up and up. And the people who had the COVID vaccine, have very few cases occurring. And in this case, there's, I think I got those slides the wrong way around. So sorry about that. So just over 30,000 people were in this trial. Again, half of them being vaccinated with the COVID vaccine and half of them receiving placebo. And again, here you can see the numbers, 185 in the placebo group who had COVID and 11 in the vaccine group. And again, the efficacy overall is 95%. If we look at the breakdown of the demographics in this population, again, it's around 50-50 male-female. Here they differentiate between 65-year-olds and over rather than 55, and so around a quarter of the study was done in people who are 65 and over, and a similar breakdown in terms of race and ethnicity. Majority of people were white, just over 20% Hispanic or Latinx, 10% Black or African American, and smaller numbers of other minorities. And I haven't listed every single one here, but because the numbers are even smaller percentages than this. In terms of the side effects, so this just compares the side effects for these two. So this BNT161B2 is the Pfizer vaccine, and this mRNA is the Moderna vaccine. This comparison to 2 flu vaccines that are currently used in BC. So Fluzone is one of the flu vaccines that is given to most adults in British Columbia, and Fluzone higher dose is used in some people over 65. And so this year in BC, this was the vaccine that was mainly used in, for example, long-term care residents. And so pain at the vaccination site for both of the mRNA vaccines, so most people will get pain, so 7 to 9 people out of every 10, which is higher than you would expect after the flu vaccine. So this vaccine is going to give more sore arms than the flu shot normally does. In terms of the more systemic symptoms, so fatigue occurring in 3 to 6 people out of every 10, and headache in a similar number. And again, compared to the flu vaccine, this is higher than we see with flu vaccine, where it's 1 to 2 out of every 10. Chills in 1 to 4 out of every 10 people, muscle pain in 1 to 5 out of every 10 people. It's pretty similar for these two vaccines, which is In the flu vaccine, it's around 2, so similar, maybe a little bit higher in some people. And joint pain also occurring in a reasonable number of people. So again, anything between 1 and 5 out of 10 people will get joint pain, and the 2 vaccines are similar. The other thing to point out is that for both of the studies, they did find that people who were older, so over 55 to 65, had slightly less of these side effects than people who were younger, and also it was slightly higher after the second dose than it was after the first dose. While some of these numbers seem quite high, I think it's worth highlighting that less than 1% of these was classified as a severe event. So very, very few of these were cases where they interfered with people's sort of day-to-day activities. So they were mostly classified as mild or moderate. And then in terms of who is getting vaccinated, so this is this is available on the BC website, and also I know Bonnie Henry has talked about this. I think the first thing before going into it, I would take it a little bit with a pinch of salt. This is the sort of structured, I think the order is probably roughly going to be correct. Just the timings may vary depending a little bit on what proportion of people fall into these different groups. And some parts of BC have higher numbers, for example, of their population in long-term care than others, and so may take longer to get down to the other groups. And obviously, there's been a lot in the media this week about interruption to supply for the Pfizer vaccine, and these interruptions may well continue to occur intermittently, and so the timeline may also be pushed. But essentially, the order is the thing to focus on. So the initial priority is being given to resident staff and visitors to long-term care and assisted living residences, followed by those individuals who are waiting such long-term care placements. Then the next priority is being healthcare workers providing care for COVID patients and remote and isolated First Nations communities. Following that initial rollout, the next plan is to go into seniors in the community, starting with the individuals aged over 80 and then gradually working downwards in age. Indigenous seniors and Indigenous elders and Indigenous people aged 65 years and older are also included in this initial group, and so the age cutoffs in Indigenous populations is slightly lower than it is for the rest of the community. Other relatively high priority groups are those with homelessness or using shelters, people in correctional facilities, people in group homes or mental health residential care, other long-term home support recipients and staff, and then other healthcare workers such as hospital staff, community GPs, and medical specialists. And then beyond that, there'll be further prioritization done of populations moving forward, but this is the initial plan for the first 2-3 months of the vaccine campaign. So for people who want more information for either COVID vaccines or vaccines in general, the Immunize BC website is a really excellent website. It has a lot of good information. It's focused on providing information for the general public, so it's relatively simple and easy to navigate and provides quick answers for the most part. For people who want more detailed information or want more technical information, then the BC CDC, the BC Centre for Disease Control website, contains a ton of information about the either COVID disease itself or the vaccines, and includes also the plan for distribution of vaccines. And then this is our website at the Vaccine Evaluation Centre. So that was all the slides, and I'm happy to go into the Q&A session.
Great, thank you so much for that really helpful overview. Just before we go into the pre-submitted questions, there's a few questions that have come through in the chat, which are clarification questions on the slides that you've just presented on. So I'll run through a couple of those first. So the first question we got is, what is RNA on the list of manufacturers? So what does RNA mean?
Yeah, sorry. So thank you for that. And sorry, I glossed over that. We tried to not have too many slides to give people chances to ask. So RNA is it's ribonucleic acid. So this is essentially the genetic material that is the virus. So as we have DNA that is essentially the instruction manual for our body and our cells to produce whatever we need to produce that determines eye color, hair color, and the rest of it. Some viruses have DNA as their genetic material, and some viruses have RNA as their material. So the COVID virus is an RNA virus, so it just has that piece of RNA. And so these vaccines, so if you compare to, say, a flu vaccine, so a typical flu vaccine will take the flu virus, it will be inactivated in some way. So you have the flu virus and the proteins that make that virus, and then it's chemically treated, and that's used as the basis of the vaccine. And so what you're injecting are the proteins of the flu virus. The difference between that and these RNA vaccines, so both the Pfizer vaccine and the Moderna vaccine are RNA vaccines. So rather than injecting the proteins of the virus, we're actually injecting the genetic material of the virus itself. So essentially it's the sort of instruction manual of the virus. And then what happens is that goes into your cells, and your cells then make the proteins, and that sort of is how the proteins are made. So it sort of uses the human cells to do the work, and it's one of the reasons why these vaccines can be developed very quickly, because that means that isn't being done in the lab beforehand, and that essentially is what happens as well. It's what happens as part of natural infection, is that these viruses infect your cells, and then your cells make the proteins. But in this case, it's only it's only the RNA from one of the proteins, so it's not a virus, it's not infectious, and it can't cause COVID. So it's just the thing that's actually injected is the RNA rather than the proteins of the virus.
Thank you. And the point you made there about speed leads nicely into the next question, which was a clarification that the vaccines that have been approved by Health Canada went through 3 of those phases in less than 6 months. Is that right?
Yes, so the first phases, the phase 1s probably started in March, April time. The phase 3 trials started around August time, and so that 4-month follow-up essentially is until around November. And so yeah, it was very, very quick. And so we have, as I said, it was really on the basis that most of the side effects that we see from vaccines occur in the first few days after the vaccination. It's very unusual to get side effects happening later on, particularly several months afterwards. So that was one. And then 2, I think, even though, so these are some of the biggest vaccine trials that have ever been done before vaccines have been approved. And so we have, I would say, very good short-term safety data, and long-term safety data, I guess we'll have to wait and see. But even within any trial, even if you have 100,000 people, that's still a very different scale to vaccinating a population where you're vaccinating millions, hundreds of millions of people. So I think for the extremely rare side effects, you're never going to see those in any phase 3 clinical trial, no matter how long you follow up for. So those are only going to really come to light once people are vaccinated in a campaign. So I would say we have excellent safety data in the short term. There's clearly, as said, even the trials are up to 4 months, so we don't have very long-term safety data, but for vaccines, that's usually less of a concern.
That's helpful, thank you. And then one more question about the efficacy data that you had was whether that graph is based on efficacy after the first dose or after both doses of the vaccine.
Yeah, so that's a great question. So the graphs go from the first dose, so those lines go from the first dose, and if you remember, the lines are essentially overlapping for the first couple of weeks, because it takes at least 2 weeks for any sort of immune response to occur. The 95% efficacy, though, those numbers is based on the number of cases that happened at least 1 to 2 weeks after the second dose. So that 95% is definitely an efficacy after 2 doses. Having said that, when analyses have been done of the efficacy after just the 1 dose, it was around 90%, with the caveat that that's a relatively short term, because you have a relatively, the Pfizer vaccine is in the trial was given at 21 days apart, and the Moderna vaccine at 28 days apart. And so that 1 dose data is relatively short term. So while it's not going to go from 90% to 0% if you never got the second dose immediately, we don't know how long it would stay at 90% for.
Great, thank you. And we've got another question on the efficacy, which is that this person wants to know, based on the 95% efficacy results and the fact that all vulnerable people are planned to be vaccinated by around March, would you expect the graph of COVID deaths to trend down to 0 pretty quickly?
I would hope so. I think, the caveats to that are always that, clinical trials in real world are never exactly the same. So I think a lot of the people that have been prioritized very early on, while the trials did their best to go up to older age groups, there was very few people sort of over 80, for example, and, people with very unstable diseases and other medical conditions, people who were immune suppressed, for example, were not included in the trials. And so we would expect to see maybe slightly lower effectiveness from the vaccine than the 95% in the trial once it's in the real world. And that's an ongoing, that will be very closely monitored in BC and elsewhere to see what it looks like in the real world. And I think the other piece is that, I'm sure you've heard a lot of the media attention about the variants that are occurring with this with the virus. So the virus is evolving, it's mutating, there are variants coming from different parts of the world. And right now, we don't know if the vaccine effectiveness will be the same or less against those variants. So I think, if things are replicated exactly as they were in the trials in real life, then yes, we would see, very few, if any, severe cases and deaths in the next, once you get a few months into the campaign. But I think in reality, that has to be closely monitored, and how things play out in the real world, we don't know. But we expect it to have a significant impact.
Of course, yeah, thank you. And I think that helps answer another one of those questions that's come through, which is what happens when the virus mutates.
Yeah, so that's a great question, and I think that the honest answer is that we don't know. So people are working really hard to use blood samples that have been collected from people who have been vaccinated, and in the lab see how effective antibodies from those people are against these viruses. And ultimately, though, I think that, the proof is going to be following things in real life. Even whatever happens in the lab may or may not be what happens in real life. So I think that, I think we're very lucky in BC. We have a really good public health system. And so we are collecting those virus samples. We are sort of sequencing the viruses to see if those variant strains are occurring in BC. And it's something we can monitor over time. So I think we will soon know, not only from BC, but elsewhere in Canada and internationally, if we're starting to see a lot more variants occurring, and if we're starting to see a lot of these occurring in people who have been vaccinated.
Sure, yeah. So I'm going to move on to a couple of the questions now which have come through about the side effects bit of your presentation. So one question is, how long do the side effects last? And then another one, which is about specific side effects. One of our participants says that they're aware of 2 vasovagal responses in different individuals, and they want to know whether that's listed as a potential side effect of this vaccine.
Yeah, so most of the side effects occur in the first, 2 or 3 days after being vaccinated with these vaccines, as they do for any vaccine. So that's when you'd expect the majority of side effects to occur, and most of them, resolve by themselves within the first few days. So that's that one. In terms of the vasovagal responses, I think that, so these sort of fainting episodes, I guess, if you like, I think that does happen with almost any vaccine. And certainly, I run the vaccine clinic that we have here at the Children's Hospital, and we've had a couple of kids, I think both adolescents, who have ended up having these sorts of responses after just other routine vaccines that we give. So I would say that's a general response that can happen to any vaccination. I wouldn't say it's something that has been identified particularly as being associated with these vaccines. And, I think the usual things that we do to try and make sure people are well fed and well hydrated and rested and whatnot before vaccinating them, goes for these as it would for any other vaccine.
I think we've got a couple more with questions about side effects as well come through. So one is whether there is any research on how the vaccine reacts with other medications. So for example, insulin. I know that was something that came through in our survey as well. Yeah,
so people with what I would say with described as stable chronic medical conditions were not excluded from the trial. So people, for example, with diabetes, if you question about insulin. So people with diabetes who had stable diabetes and were on insulin or on anti-diabetic medications would have been included. And so we would not expect the vaccine to have an interaction with other drugs.
That's good to know. Thank you. And then in terms of allergies, someone wants to know that they have staff that work who have allergies, and whether there are any specific allergies that put people at higher risk for an allergic response to the vaccine, and who should people ask if they don't have a family doctor or if they're concerned about an allergic reaction to the vaccine?
Yeah, so right now the only sort of allergies that are being considered as sort of caution to being vaccinated are people with an allergy to any of the ingredients that are in the vaccine. And so clearly, if you have an allergic reaction to the first dose, then you may need to be assessed before you have the second dose. There's something called PEG, or polyethylene glycol, which is in both of these vaccines that some people do seem to be allergic to. And then there's another, that's basically all that's in the vaccines that people might be allergic to. So I think people who are allergic to other drugs or other medicines that are not included in the vaccines would not expect to be at higher risk of having severe allergic reactions. I think for people who don't have a family physician, then I think that's something to discuss with the public health nurse or whoever it is who's doing the vaccination. And there's been a lot of education, a lot of work done with the frontline immunizers to try and enable them to have these conversations with people. We're very aware that it's really hard for people to always have to go back to their family physician or go back to their specialist if they have a medical problem which involves specialists to ask all these questions, and so it just delays everything. So we're trying to arm the public health nurses and the other frontline immunizers with all the information they need to be able to answer your questions. So hopefully they will be able to answer them. If there's any concern about allergies, we have set up in collaboration with some of the adult allergy specialists a clinic where people can be referred to if there are concerns, and additional assessment can be undertaken with a specialist. And that's really being reserved for those people who have either a reaction to the first dose or who are thought to have an allergy to one or other of the vaccine ingredients.
That's helpful, thank you. And is that clinic at UBC?
Yeah, so the allergy, so we have one clinic at Vancouver General Hospital, and then there's also some allergists on Vancouver Island in Victoria who also have a clinic.
Wonderful, thank you. We've got one question which is, I know was popular in our survey as well, and I think a couple of people have resubmitted it prior to this webinar, which is about how long the protection from the vaccination will last. So is it likely to be a one-time thing, or is it going to be like people who take the flu shot annually?
Yeah, that's a great question. So in the trial so far, those data and the basis for that 95% efficacy essentially is a 4 month from the first dose. So I guess 2.5, 3 months after the second dose has been given, and so we know that it's 95% for that period of time. What is reassuring to me, if you look at the sort of the way those lines are going, it doesn't look like, towards the end of that period of time, that vaccine group was starting to accumulate more cases. So I would expect that it would last beyond that. Exactly how long beyond that, it's hard to tell, because that longer term follow-up is not being done yet. So I think that's something that we're going to have to find out by sort of the analyses of people who are being vaccinated as we go on. In terms of the need for this vaccine as a sort of regular vaccine, so I think there's two things that will depend on. One will be how long does protection last. So if protection lasts for 2 years, say, then clearly you wouldn't need to get it every year. So that's one thing. The other is what happens to this disease as we move forward, and what happens to the pandemic. So if we see over time that this continues to be a very severe disease and people can get repeatedly infected, then we may well need a more frequent vaccine, whether that's every year or whatever it is. If we find that once you've been vaccinated or once you have been infected, that if you do happen to get infected again, it is a very mild disease, or it's only severe in specific people, then it may be that once you've had your initial vaccination and everyone's been vaccinated, or most people have been vaccinated or infected, that in future vaccines would be targeted at those high-risk groups only. So I think, because a little bit is the risk-benefit, right? So right now, this is a really severe disease, it's worse than influenza, and so the disease itself is really bad, and we have vaccines that can prevent that. If the disease is not as bad, then I guess there'll be further discussions and further assessment of the need and the risk-benefit of that.
Great, thank you. And a couple more questions, just going back to the side effects, following up on the discussion about allergic reactions. One person wants to know whether any of the allergic reactions have resulted in deaths.
Yeah, that's a great question. I was just double checking. There was a recent report out from the US that had some allergic reactions. I don't think any of them, just give me 2 seconds. I don't think any of them died as a direct result of their allergic reaction. So I would say that, you know, all of the immunization clinics that are currently being run are equipped with adrenaline or epinephrine, which is the initial sort of emergency treatment for a severe allergic reaction or for anaphylaxis. All of the nurses who are immunizing are fully trained to deal with that. And in general, we're seeing, you know, so for example, from this report from the US recently, from the Pfizer vaccine, there was around 1 case of anaphylaxis for every 100,000 doses that were administered. So that's the kind of, you know, frequency we're talking about in terms of the very, very severe events.
Thank you. I can see that there are a few more questions coming in on side effects, but just with an eye on the time, I want to make sure we move on to some of the other topics that people have raised. So to those people in the chat, I will still try and get to you. But one of the questions that was pre-submitted and again came through a lot in our survey was around people who either plan to have children, who are currently pregnant, and who are breastfeeding, and whether any of those 3 groups should be concerned about the vaccine in any way.
Yeah, so that's a great question. It's a really common question. So as you might predict and as you might expect, anyone who was pregnant or who was breastfeeding was excluded from the clinical trials. So there are relatively very small number, you know, I think, you know, a dozen or less people that happened to become pregnant while they were on the trial. So they didn't know at the time they were vaccinated, and then afterwards it became obvious they were pregnant, and so they will be followed up. But that's really too small a number to be able to draw any conclusions from right now. So I guess it goes back to what I was saying about the risk versus benefits. So we know that people who are pregnant seem to have slightly higher risk of adverse outcomes from COVID infection if they're pregnant compared to sort of age equivalent non-pregnant individuals. We don't have any specific data in pregnancy for this. I'll do the pregnancy and breastfeeding separately because I think they're 2 separate things. So we don't have any data in pregnancy specifically for these vaccines. There are, I know there are some people, so as we go through those risk populations that I mentioned, so for example, there are healthcare workers who are pregnant, who have been sort of called for vaccination and who have been vaccinated. And the plan is to closely follow anyone who is pregnant or anyone who is in any population that was not in the clinical trials to see if their side effect profile is different. In general, historically, vaccines have been divided into 2 types. The live vaccine, so where you use a weakened form of a virus to vaccinate. So measles vaccine, rubella vaccine, chickenpox vaccine are those sorts of vaccines where it's a weak virus, doesn't cause a problem in most people. If you have anything wrong with your immune system, it can still cause a sort of measles-like or rubella-like illness. And then there are other vaccines which are not live vaccines, not weakened forms. They're just completely inactivated or bits of viruses or bits of bacteria that can't cause disease. And in general, we would regard that those non-live vaccines are safe in pregnancy, and it's the live vaccines that we avoid during pregnancy. So these are non-live vaccines. So sort of based on the theory, then, you know, there's theoretically no reason why they would not be, you know, safe from that perspective in pregnancy, although we don't have the data. But I guess the only question that has been raised is that we know that, as you saw, that they do lead to more side effects in general compared to something like a flu shot, which is given and recommended in pregnancy. So there's a question about whether, because there's more inflammation, that might cause a higher risk to the pregnancy. And so it's, you know, we're in this sort of unknown right now. And so the official guidance is that, you know, if pregnant people who have other reasons why they're at increased risk can be vaccinated on a case-by-case basis, essentially after the sort of, you know, a discussion with the immunizer in terms of the fact that, you know, we don't have much data on pregnancy. We know that pregnancy slightly increases your risk of having more severe disease if you're infected with COVID. We in theory, the vaccine is probably okay, but we don't know yet. And so I think that's a little bit an individual decision. I think, you know, if someone, and I think it depends on your own personal situation. I think in the breastfeeding side of things, I would be more comfortable. I think there's no again, there's no sort of theoretical basis in which you would expect this vaccine to be transmitted, if you like, through breast milk to the infant. And so I think that is more straightforward. But I know that in general, a lot of pregnant people have already been vaccinated. And so I think, as I said, the safety data will come over time. And there are clinical trials planned for people who are pregnant. And the other piece of that is that there's been some animal data for pregnant animals, and there's not been any evidence of adverse events or malformations, congenital malformations, or that sort of thing from those studies that have been done so far.
And could you talk a little bit about the third element related to that, which is around fertility? So there have been some questions about whether there is any side effects in relation to fertility and people who plan to have children in the future.
Yeah, so again, we don't really have any data on that. I guess it's really difficult to know if, women of childbearing age have been vaccinated, whether or not that has an impact on their fertility. I think fertility itself is just so complicated and multifactorial. Again, from the animal data that we have so far, there's no evidence that these vaccines have an impact on fertility. But I think right now, we can't say with 100% certainty that that's not going to be the case.
Great, thank you. But there's no data to suggest that it would impact.
No, that's correct. There's no data to say that these vaccines would cause infertility. And I don't know of any vaccines that actually have been linked with infertility that are being used.
That's helpful, thank you. One of the other questions we had pre-submitted was related to the efficacy of the vaccines, and it was asking if I get the vaccine, can I still be a carrier if I'm near someone who has COVID, and do I still have to wear my PPE and do social distancing after I'm vaccinated?
Yes, that's a really, really good question. So just to go back to the trials that have been done, so when they're measuring efficacy, what they're using, and those graphs that I showed you, what they're measuring are people who had COVID with symptoms. So you had to have two things to be included in those numbers. One, you had to have symptoms of COVID, and two, you had to have a positive test through a nasopharyngeal swab to test positive for COVID at the time of the symptoms. And so we don't know right now. So that's one. So we, in terms of, and the process of infection is that you get infected. Most people get symptoms, some people may not get symptoms, and then either way, you're able to transmit to other people. And what we don't know with these vaccines, because the endpoints that were being assessed were people with COVID and symptoms, was whether the vaccines completely prevent infection itself, in which case that would be fantastic, and then you wouldn't even be able to, you can't be infected, you can't transmit it to other people, or whether they don't necessarily prevent infection, but they just prevent infection establishing enough to cause symptoms and to cause severe disease. And so without knowing that, I think right now we'd have to say that, it's still possible, even if you've been vaccinated, for people to be infected, albeit maybe asymptomatically. And if you're infected asymptomatically, you'd still be able to theoretically pass it on to other people. So I think the upshot of all of that is that even if you've been vaccinated right now, it's still important to follow the public health guidance in terms of social distancing, personal protective equipment, and everything else until we have more information on the ability of these vaccines to prevent infection and asymptomatic infection specifically.
Thank you. So you're saying we do know that the vaccine protects you as an individual from getting sick from COVID, but the distancing measures and the PPE are important for those around you until we have that data.
Correct.
Great, thank you. And a related question to that, I guess, in some way was pre-submitted around people who have already had COVID, either symptomatically or have had a positive test, and whether those people need to get vaccinated or do they already have protection?
Yeah, so that's another good question. So right now, we don't know how long protection lasts after you've been infected. So in general, so there's two things that happen with your immune system in general to protect you against infections. So one is you have antibodies that can be produced, and one is you can have T cells, which are also really important for fighting off viral infections that can be produced. So these vaccines, one, they lead to both antibody and T cell responses, but infection also does the same thing. And right now, we don't know which of those is more important. So we know that after you've been infected, your antibodies will last at least 8 months. And so that's, there was a really good study reporting on that a couple of weeks ago. And we know your T cells will last at least around 3 to 5 months. So we're not seeing a huge number of people getting recurrent infection. So presumably infection does lead to protection, long-term protection for most people, but we don't know how long that is for. In terms of whether or not you then be vaccinated, I think that because we don't know, I think the bottom line is yes, you would, if you're recommended to be vaccinated, you should still get vaccinated. The only comment I would make is that right now, just with the initial supply and trying to prioritize use, I know that some people who have been recently infected are sort of being deferred onto, on the basis that they probably have some protection from their infection, and people who have never been infected are being prioritized. But I think in general, once we, get through these initial issues around supply, everyone will be vaccinated whether they've been infected or not. And in the clinical trials, people who had been infected in the past and even had antibodies against COVID were not excluded from the trial. So we know that in those trials, we had both people who had been infected before and people who had not.
Great, thank you. So those people who are currently being deprioritized because they have already been infected with COVID, it doesn't mean that they won't or they shouldn't get the vaccination, just that when we have a limited supply, they're considered a safer right now.
Exactly. No, really.
Great, thank you. One question is about the distribution, which is how are the needles being disposed of after a mass vaccination campaign?
Yeah, so that's a good question. So in general, the needles go sort of at the point of injection, they go into the sharps bin, and then all the sharps bins go somewhere and get incinerated. So I'm not involved in that side of things, but I presume that there's a lot of incineration going on.
Great, thank you. And then I'm flipping back to some of the questions that were pre-submitted now, and people were asking about how long after the vaccines and the vaccination campaign takes place would we expect herd immunity?
Yeah, that's another good question. So just, thinking a little bit, and people understand different things by herd immunity. So the way herd immunity works is essentially getting to a point where enough people are vaccinated in a population that everyone is protected. And that depends on how infectious something is. So it depends on how infectious something is, and also whether or not the vaccine completely prevents infection. So if you take something like measles, so the measles vaccine will prevent measles infection. It doesn't just prevent people getting bad disease, it prevents the virus even infecting in the first place. And it's very, very infectious. It's one of the most infectious viruses we have. And so once 90 to 95% of the population have been vaccinated, essentially so many people have been vaccinated, there's not enough people for the virus to sort of spread through the population that even that 5 to 10% who haven't been vaccinated will be protected. And that is sort of what, if you think of the population as the herd, that is what people sort of generally mean by herd immunity. With these vaccines, because we don't know yet if they completely prevent infection, and including asymptomatic infection, we don't know if they will prevent or if they will lead to herd immunity at all. If they do prevent asymptomatic infection, then we would expect that we would need probably at least over 70% of people to be vaccinated to get herd immunity, although it may be that if you got really high uptake in the populations that are spreading it the most, you could get the same impact.
Thank you, that's helpful. So it's another one of those things that we need to keep looking at the data on.
Yeah, exactly. And if we start seeing, once we get more people vaccinated, if we get to the point where we start seeing rates, because what gives you a clue that there's herd immunity happening is you start to see rates decrease in people who are not being vaccinated. So if we start to see rates decreasing in people, even who haven't been vaccinated, I think that will be the first clue that we're seeing herd immunity from who's being vaccinated.
Great, thank you. Just a note to our participants that we've got about 10 minutes left. So I know there are a couple more questions in the chat, but if you do have any questions you want us to try and squeeze in those last 10 minutes, please do pop them in that chat box and I'll try and get to you. We have a couple more come through in the chat about the side effects again. So one person is asking what that less than 1% that had severe reactions, what did those look like? What kind of reactions were they? And another person asking whether it's becoming more obvious that side effects are much more severe after the second dose of the vaccine.
Okay, so I'll deal with the second question first, because that's easier. So I think that that most of that information about being more after the second dose. I mean, you're talking about a 5 to 10% higher compared with the second dose compared to the first dose, so it's not a huge difference. And then I think in terms of, it's becoming more obvious because, more and more people are being vaccinated. In terms of the side effects that are being reported now, we're only really, the focus on reporting side effects is only those really severe ones that result in people ending up in hospital or requiring medical attention, or something that's a really rare or unusual side effect. So those are ones that are being reported. So right now, we wouldn't expect, a sore arm or a bit of redness at the vaccination site or having a bit of a fever to be reported. In terms of the less than 1%, so essentially the way clinical trials track side effects is that if you're in a vaccine trial, you will get given a diary, and something that used to be paper, and now a lot of it is done electronically. And on that diary, there's a list of symptoms that you're asked about. So there is, pain, redness, swelling, those sorts of things at the site of injection. And then there's just general things of, do you have any muscle aches, joint aches? Do you feel tired, headache, fever, and that sort of thing. And so what people are asked to do is for every day for a week or so after the vaccination to fill out this list of, on each day, did they have any of those things? And then if they did, they have to grade them. So if it's a swelling, you get given a little measuring tape and you have to measure how much the swelling is, and the same for redness. If it's some of these other things, like if it's a fever, it depends how high the fever is. And if it's other things like headache, it depends on how much it interferes with your daily activities. And then based on that scale, each of them is graded as mild, moderate, or severe. So when I said that less than 1% were severe, it's all the same things that were, the common things that were happening. So the sore arms and the headaches and the fatigue. It was just that around 1% of people regarded those as severe, whether that's based on the measurement of the fever or the measurement of the redness or the fatigue or a headache that interfered with their daily activities. So that's generally so the severe just is a grade of those symptoms rather than being sort of completely different set of reactions. And then clearly if other people have other reactions that they would like to report, then that is also reported through the same system.
Okay, great. So the severity is about the feeling of the person who's recording it, who's been vaccinated, and how much they feel it's disrupted their life.
Correct. So a lot of it is, subjective. Clearly, with the things that you measure, like the fever and the measuring the redness, that's very objective. But other things, it's really around whether they had to seek medical attention and how much it's interfering with their daily activities.
Thank you. I've seen 2 more questions come through into the chat. So looking at the time, I think those will probably be our final 2. So the first one is whether there are studies being done around the efficacy of booster shots and whether there might be similar issues with additional shots as we see with antibiotics, where they lose their effectiveness over time.
Yeah, so the booster shot, I presume people are referring to, whoever asked the question is referring to boosters beyond those initial 2 doses. I mean, some people would call that second dose a booster. And so I think those studies will come, and the interval will depend a little bit on how often we think people will need to be vaccinated. I'd say for most vaccines, what we actually find is that booster shots boost, that by different, by the name is there, so they boost the immune system, so they actually are often more effective, and the reason for that is that the first time you have a shot, then it's the first time your immune system has seen that virus or part of that virus, and so it takes a little bit of time for the immune response to occur, so usually a couple of weeks. And then if you're having a booster, because your immune system has seen it before, that response is much, much quicker. So usually within a week or so, you will have a response. And for most vaccines, actually your antibody response after a booster is higher than it is after the initial shot. So I think we would expect boosters to improve the immune response rather than to lessen it.
So it's a refresher course for your immune system.
Pretty much.
Thank you. And then the final question, which I think ties in nicely to a question we saw come through quite a lot in the survey around the risks of vaccination versus the risks of getting COVID and how you weigh that up. So this question is a particular scenario, which is it safer not to vaccinate a 93-year-old if she lives at home and has no contact with others outside of her household bubble?
Yeah, I mean, I would say someone in the group is, at very, very high risk of having severe disease if they get infected. That's some of the highest. Age is the single biggest, increased age is the single biggest risk factor for getting severe disease. And the higher your age, the higher that increase is. So someone who's 93 is like way higher risk than someone who's in their 20s or 30s. So I think the risk of severe disease one is very high. And then I guess a little bit comes down to whether, even in your bubble, it's unlikely that you're going to completely be able to isolate your entire bubble from the rest of the world. And so while your 93-year-old may be at home and only interacting with a few people, those other people will be out there interacting with other people and may get infected. We don't know, particularly with children, we think asymptomatic infection occurs more than it does in adults. And so they may unknowingly be infected and then infect other people in the household. And what you have there is someone who's highly vulnerable. So if it was me, and I think those would be the highest priority for vaccination, to be honest, because they have the most to gain from the vaccine. And even still the vaccine side effects are a little bit lower in older people. And even if you say, well, 93 is older than was any of the trials, and how do we know it's going to be 95% effective? Even if it's only 70% effective, that's still pretty effective vaccine that is similar to what we have for an average flu shot every year. So I think, to me, the most vulnerable people would be the highest priority to vaccinate. And I don't think we can completely rely on this sort of social distancing measures to be 100% protective.
Great, thank you. That's really helpful. I know that there are some questions coming through, but I think we're about to run out of time. So I apologize to those few questions in the chat and the couple pre-submitted that we didn't get to. But I just want to say thank you again for your time. I think that's been really informative, really helpful. And I hope that those of you who have dialed in to participate have found it useful as well. There will be a recording of this webinar up on the SafeCare BC website. And I believe we will be running another of these sessions in February as well for those who didn't get to sign up today. There is also, I believe, my colleague Zach has put a link in the chat to the SafeCare BC vaccination page, where we are collating resources from useful sources like the one that Dr. Sadarangani cited on his slides earlier, from the BC CDC, from the World Health Organization, and all of the other credible sources of vaccination information that we have. So Dr. Sadarangani, was there anything else you wanted to say before we sign off?
No, I just saw one question there about the last question, so I can answer that really quickly, of whether people can choose which vaccine they get, and basically the short answer is no.
That's helpful, thank you. One final thing to everybody before you all start hanging up on the call, which is that I believe my colleague Reese is about to put a link to a survey in the chat, just for you to give a very quick bit of feedback on this webinar, on whether you found it helpful, whether there is anything that we could improve in future. So if you wouldn't mind, some of you taking the time to do that, we would very much appreciate it. There we go. There's the link in there now to the SurveyMonkey. So I will leave this call open for a couple of minutes for people to click on that. But thank you again for your time, everybody, and stay safe until we can all get vaccinated.
Thanks, Jennifer. Thanks, everyone.
Thanks. Bye-bye.
Bye.